Hello, everyone, and welcome to another episode of Arthritis at Home. My name is Ellen, and I'm the program's coordinator. Today, I'm joined by Kasra, who is an international medical graduate and is currently pursuing a Master's of Science in Experimental Medicine at the University of British Columbia and Arthritis Research Canada. He is supervised by Dr. Diane Lacaille and recently won the Mitacs Award, a very prestigious fellowship. And with that, Kasra is examining some administrative data to learn about, in this case, side effects of biological agents. But we'll get into that a little bit later. With that, thank you for joining us, Kasra. It's really great to have you today.
Thank you. Thank you, Ellen and Ace, for having me. It's a pleasure to be here.
So Kasra, can you tell us a little bit more about yourself and how you got involved in rheumatology at Arthritis Research Canada?
Well, thank you for your kind introduction. As you said, I'm an international medical graduate. I did my training back in Iran, and now I'm currently doing research with Arthritis Research Canada and Dr. Diane Lacaille. Honestly, I started to become more interested in internal medicine research when I was going through my rotations in medical school. But then I wasn't very specific about the subspecialty or the field. But when I was going through different articles and the manuscripts, I saw a couple of papers that kind of sparked my interest. And then I'm pretty sure that you also can feel this. When you go through a researcher's portfolio, you see some patterns. And when I was going through Dr. Lacaille's research portfolio, I saw how interested she is in actual real-world practical questions that will influence the lives of many patients. And also some other themes that she is interested in trying to be helpful to the community and focusing on some underserved communities or maybe indigenous populations here in Canada as well. And like these were the things that made me gravitate towards her research. But at the end of the day, I am very grateful to be here from Arthritis Research Canada and Dr. Lacaille to be a part of this research.
Kasra, you bring up two really interesting points I want to highlight with our audience. Is number one, rheumatology actually falls under internal medicine, which is really interesting. Internal medicine being, very broad, and as Kasra pointed out, subspecialties. There's several subspecialties in there, and we always get asked the question of how we found our supervisor, and really it is this. I stalked someone on the internet and I found their research really fascinating. And then when I saw a video of them speaking, they seemed like a real person. And there was something about their interests or how they held themselves or how they spoke about a specific population that really you're like, yep, this is for me. And as serendipitous as it all sounds, it really is that. It really is that. And, I want to congratulate you for not only being like, yes, I want to do this, but yes, I want to do this and fly across the world and come to a country you've never been in before and learn a whole new language. And then on top of that, win, a very prestigious scholarship. Kasra, I do want to highlight and congratulate you again on that. And then Kasra, with that, let's dig a little bit deeper into your research. So from my understanding, you took administrative data. You'll have to tell me where this administrative data is from, but for our audience, administrative data is the data that they keep when you go to, whether that's the doctor or the hospital. So Kasra will let us know in a minute, but it's like a lot of information, right? Data is just another word for information, but they may have, the duration of your arthritis, the type of arthritis you have, what medications you're on, but it's a lot of data and it's very specific data to rheumatology, to arthritis. And then what could we do with it? Well, Kasra will let us know, right?
Of course. Okay. I'll try to delve into what admin data or population-based studies are. So basically, as you mentioned, whenever we try to pursue any sort of healthcare related thing, like, for example, visiting a doctor or going to the ER, or if it's refilling medication. The advent of our healthcare system here in BC has been that all of these information are collected and then anonymized. So all the personal information will go out, and then the thing that will be left will be different sort of information. And here, Population Data BC has kindly collected all of these information together and put them in the same database. And now researchers can contact the Ministry of Health and Population Data BC, propose their research questions, and tell them, hey, we are interested to know, for example, what are the infection rates of these certain drugs in this certain population. We will go through a rigorous ethics training, and then we will be granted access to very specific, again, as I said, anonymized data, and we will be able to analyze and try to kind of get that the answer to the question that we were looking for from real world setting data.
No, it's a very resourceful way to take something that we already collect, right? We have to collect data on nutrition. No, we have to track as healthcare professionals the medications that someone takes, right? If they've had infection, allergies, all these things. And then to be able to use it to answer specific questions. Kasra, can you tell us specifically what questions were you trying to answer with this data?
So biologic drugs, or biologic disease modifying antirheumatic drugs, which we also call DMARDs, have become a staple of treating inflammatory arthritis. There are different disorders that are treated within the family of inflammatory arthritis. For example, rheumatoid arthritis, spondyloarthritis, and psoriatic arthritis. These are the main top 3 inflammatory arthritis that are currently being treated with biologics. So this was the population that we were most interested in. And what we were interested in was that, okay, these patients have been receiving these drugs for some time, and we know that before these drugs come into the market and reach the market, they will still go through a rigorous phases, so that all the side effects, all the adverse events kind of become known to the healthcare providers. But still, what will happen when the drug actually reaches the market? Because then in the real world, a lot of unknown variables will come into play. Then there is the question that, okay, so we have tested out these drugs in a controlled environment. What will happen in the real world? What are the differences between these drugs? And although we know biologics, because they are trying to have an effect on the immune system, will have some side effects with that regards. For example, we know most biologics, almost all of them, will increase the risk of infections. But what is the difference between those classes of biologics? Because we have different classes of biologics which work with different mechanisms of action. And for example, in a real world scenario, if you have patient A, Kasra, comes in, and you know that this patient is more vulnerable to having an infection. And when you want to decide between drug A, B, and C for that specific patient, how can you individualize that treatment to serve the purposes of that specific patient. For example, if we know drug A, or at least the family or class of drug A, is more risky for patients who are more lenient towards, more vulnerable towards infections, then we might choose a drug from class B. This real life scenario was kind of the research question that spurred on this research project.
Yeah, it's so interesting. And I see the practical application of this already. So, Kasra, if I can repeat back to you. So you really are looking at adverse events, in this case, infections for different kinds of biologics for several of the most common types of arthritis, to compare those side effects and then to help, down the line, help us better not only understand, but then to tailor that treatment. So we know that this individual has a history of high blood pressure, has history of diabetes. Perhaps biologic A is not the best choice. We will go with biologic C in this case, right? Because there's so many different ones to choose from. I definitely see that real life application and the importance of doing this work. So Kasra, you have this data, and I'm sure it's a lot of data. It's an Excel sheet. If anyone knows what an Excel sheet is, it's just numbers, right? It's numbers and words, and you have to process the data, you have to clean the data, you have to recode some of the data because you don't like how it's organized, and there's a lot of missing ones, so you have to go digging for some of those missing values. And then Kasra, then you have statistical software, right? You take that data, you put in the statistical software. Could you perhaps explain to us in as simple as you can terms, like what happens to the data? Like how do you crunch the numbers, as we say in research?
There are different analysis techniques that we have used in this project. And fortunately, the team of Arthritis Research Canada boasts a fantastic roster of biostatisticians and epidemiologists that are able to help us, who come from a more clinical background and have been trained a little bit in the statistical side, to select the best types of study designs or analysis for our specific needs. So first of all, great summary of what our research question is. And alongside severe infections, which we describe as any hospitalized infection or any infection that has occurred during hospitalization, we also are interested in major cardiovascular events, which we describe as any sort of myocardial infarction or heart attacks, as well as strokes. So any blood clots in your major organs, or any death that is from that adverse event. We are interested in that as well, because this is a very life-threatening and major side effect of these drugs. And also VT, which will be venous thromboembolism. Again, any sort of blood clots in your deep veins, for example, in your lungs, or if it's deep within the veins of a muscle in your calves. We are also interested in those outcomes. And for these different outcomes, we need different statistical techniques. For example, count of infections needs a whole different model. And whereas an event which happens mostly one time, for example, we cannot die twice. That's an outcome that only happens once. We tend to look at the time that has that infection has occurred, and we try to compare the time of starting the drug until that event has happened. Some of the statistical techniques that we have tried to add in order to avoid bias, and let me just describe what bias is in statistical terms. Any sort of systemic errors that we have in our analysis, in collecting data, any step of the way, that systemic error will lead to inaccurate results. And that inaccurate result will lead to inaccurate conclusions. So we want to avoid that. And as we mentioned, like there are a lot of factors in play in population-based studies, in real-world studies. There are a lot of variables in play. What we can do is, let's go through this with an example. Patient A is receiving drug A, and that patient has some certain characteristics. And then another patient will receive drug B, and that patient has certain different characteristics. In the first phases of the drug getting to the market, we use a certain study design called randomized controlled trials, which we basically control the study and very selectively have patients that are similar to each other, and we randomize how the treatment is allocated. But in real world settings, we know that the healthcare provider will be biased towards, for example, drug A going to a certain type of patient and then drug B going to another type of patient. So how can we make that balance? How can we make that control in our study design? What we do is we try to provide a score by going through all the other variables except that exposure, which will be the drug that they have received, which is drug A or B, whatever. We give a certain score, which comes from from other variables. So basically, if you have a higher age, you have certain other diseases, then your score of receiving the treatment will be higher. And if those tendencies, if those variables are at a lower portion, then you will receive, for example, drug B. And then what we can do is basically assign a weight by that score, which in the end will make all those other variables balanced throughout different populations. So in the end, we will have a pseudo population that is very balanced for their baseline characteristics. Now that we have similar populations to compare with each other, the only difference is that if they have received drug A or if they have received drug B. So we kind of get rid of all the noise in the analysis and then end up with a result that can be more confidently attributed to the type of exposure or the type of drug that the patient has received.
It's really interesting, Kasra, because like you said, depending on the research objective, in this case, we are looking at frequency, so the number of infections, right? That is counting a number. So you add up all the numbers. But if we're looking at time, right? Time to an event, right? You might count that in months. Really, your analysis technique depends on the research question. But we also have to understand that the data we receive, even though it's real world data, there is bias inherent in it, as we all know, that socioeconomic status affects all health outcomes. Right? That's a statistical statement that I make it, right? To some degree or another. Is it statistically significant? I don't know. But in this case, what you're saying is that certain biologics seem to be given more preferably, right, by certain healthcare providers to certain patients, and that allocation is not equal. So what we then do is we take the data we manipulate it in a way so that the allocation is more equal, so that we can truly get or better understand those adverse events instead of saying, you know, the adverse event happened actually because of their age and their comorbidity status. It actually happened because of the drug, right? There's certain things that we can do when that sample size is big enough and the techniques that we use are appropriate for that population. It's very interesting, Kasra. And then thus far, what have we learned? Or what do you hope to learn, I guess, from your data?
Mhm. So we are midway in our analysis. Hopefully we will have another chat to discuss those results. But so far, what we have found is that we knew some certain drugs or families or classes of biologics were given more to patients who are who have a certain background. And even though after trying to balance everything out, get rid of all the noise, still we see that some families or some classes have more side effects, or at least in the analysis that we are doing now, severe infections, we do see some classes have a more tendency to have a high risk of severe infections. But we still have to be aware of the caveat that all of these drugs are something that change the lives of patients. And we have to be careful in the fact that, okay, if this certain class has a higher risk, we should try to avoid it for patients who are more lenient, who are more vulnerable to adverse events such as infections, but still try to utilize that for patients who need that drug for their disease. Or at least when we use those medications, we should be aware of the fact that, okay, I'll be more watchful. I'll be more alert if this side effect is happening, and to at least try to avoid the adverse outcomes that those um, infections might have.
So, Kasra, what I'm hearing is it's not that, we want to learn which biologic not to use, but we want to better understand these side effects, whether they're infections or not, so that we can better select the right biologic for the right person, because all of them have side effects. They're just
Exactly.
slightly different. All of them have slightly different mechanisms of action. They work better in slightly different populations. But right now, because they're so new and they're so novel, we don't quite understand the small nuances. And your work is really able to pick out those small nuances that could have clinical benefit. Yes, small, but clinically in the long term, it could be really beneficial for us to know that this biologic is that for better for that individual. That biologic is not preferred for that individual, so that we can continue to refine that knowledge.
Exactly. Well said.
Kasra, I am so thrilled for you, and I can't wait to have our next conversation, because I myself am not that familiar with biologics, and I would love to learn more about their side effects and how we can go about as a community of researchers to be really, really mindful and really thoughtful in how we prescribe. So looking forward to hearing about those results, Kasra.
Of course, thank you. We're also excited that we are seeing great results, and hopefully we have time to discuss this in a future episode. Thank you for having me.
Thank you, and thank you to our audience. We hope you guys join us for another episode of Arthritis at Home. And with that, take care, everyone. Goodbye.
Bye-bye.